Monika Gupta is our next speaker. She will basically be speaking on biliary drainage procedures like choledocho-duodenostomy, transduodenal sphincteroplasty, etc. Over to you, Monika.
Indications and technique of bilioenteric anastomosis in CBD stones. That is the topic allotted to me. In this, I am going to present very few surgical technique things because I think it will need a long duration to explain that, and everyone hearing me is an expert as far as I understand. So, recurrent stone, the predisposition, when we know that CBD stone, when diagnosed, removal of the CBD stones is recommended by many guidelines, as we have already discussed since yesterday, according to the British Society, European Society, American Society, and Japanese Society. Everyone says that CBD stone removal is indicated. Sometimes it has been quoted that asymptomatic CBD stone should be removed if benefits outweigh risk. That means the asymptomatic CBD stones can be left also, but that's all a very guarded thing. And they say that even only if they are higher risk, then only they can be left. ERCP was first used for unfit and sick patients in 1974, and we know that the journey of ERCP is great journey. And as Dr. Abhinav has elaborated yesterday, that largest type of stones can be removed. What are the causes of recurrent stone? How do we form the recurrent? How do it forms the recurrent stone? A large CBD diameter, which indicates more chances of recurrent stone, more than 45%. Age 65 years or more number and large stones leads to recurrence. ERC, previous history of ERCP, EPT, ESBD, endoscopic biliary dilatation leads to recurrent stones. Presence of periampullary diverticula, which leads to obstruction, can lead to biliary stones. Genetic predisposition, some genetic orientations are there, which can lead to increased formation of stones. In females, there can be more formation of stones. Lower CBD stricture due to recurrent passage of stones, which is called benign stricture at the lower end. CBD stricture, as in chronic pancreatitis, post biliary bypass strictures like HA stricture or CDD stricture. So these are the reasons where one can have recurrent stones, as well as we can have the indications of bilioenteric bypass. The risk factor which leads to increased formation of stones, as I've already elaborated, the same thing is written as a chart here. Indications for BEA, the similar thing is coming again. The indications mostly are these. Also, other indications like, in my opinion, post-biliary bypass pictures, Mirzzi syndrome type 2 or more, because more than type 2, either we do a choledocoplasty as shown by the previous speaker, or we can do a bypass like an biliary enteric bypass for the safety, or a preoperative stent is present which is left inside, because many of these type 2, more than type 2 biliary syndromes can leak through the residual cystic duct stump or a residual subtotal cholecystectomy stump, and which is a very messy thing to go on. Later on, the bypass may be needed. Altered anatomy, patients having altered anatomy like post gastrectomy, Biroth type 1, type 2 surgery, their endoscopic passage is difficult, and routine gastroenterologists, they find it difficult. Although with good enteroscopes and good instruments, they can go in the Bilroth and Rue loop also, but it's very difficult for the endoscopists to go into the altered anatomy. Doubtful, in cases of doubtful or incomplete CBD clearance, where we are on table assessing the CBD clearance and we are not very sure, although the dilated CBD is there and some soft indications of bypass is there, like aged patient who may have recurrent stones, or maybe we doubt the primary stones are there. Presence of ampullary stone, where ERCP is not sufficient. I have an example in my next a few slides. Ampullary stone impacted, which is not amenable to ERCP. Sometimes they are very easy stones, but sometimes they can be faceted stones fixed at the ampulla. The last option of having a BA, GSG with periampullary diverticulum with dilated CBD and raised ALP, but no stone in CBD. That's the question mark in my mind, which we can discuss at the end. But that's merely a query from my side. choosing bilioenteric bypass is difficult these days because uh, traditional teaching of bilioenteric bypass is very less done nowadays in the current training programs because of the availability and vast use of ERCP. More CBD stones are not coming now. Obviously, more choledocho-duodenostomy and choledocho-jejunostomy type bypass procedures for stones are not done. So one needs to have expertise and experience about doing it or seeing them. Fine patient's analysis of LFT and imaging should be fine. And it means that if patient have a chronic deranged LFT in cases of chronic pancreatitis or imaging showing dilated CBD, what is the size of CBD, whether they are primary stone or not, what's the age of the patient, all these factors are important and one needs to be finally analyzing these points. So it's difficult to know for everyone. Bad experience with bile from T-tube drainage or when there are residual stones, they can be leaked from T-tube drainage and post cholecystectomy, biliary, like stump fistula, post meresis. These are bad experience which train you that see it's better to do a bypass which is very safe in expert hands or a very trained hands. So it's not a dreadful procedure. It's a very helpful procedure which one should know. So hands-on to do these procedures is important in those cases where you know that post-operative you are going to be stuck with the leakage thing. So there we can use the bilioenteric bypass in properly indicated case. One should have a good case details as I said. Differentiation from choledochosis is important. I've recently analyzed one article where post-cholecystectomy dilated CBD was the question. So routine dilatation versus choledochosis was the discussion, and definitely stone versus choledochosis is a big discussion in our GI surgery practice. So one should differentiate it from choledochosis with the help of imaging and a history criteria. Assessment of above mentioned risk factors should be done. The surgical procedures included in bilioenteric bypass, as I will like a few inputs from senior faculties because in our times we have seen less of them, more we have read more but seen less. Although regarding the choledocho-duodenostomy thing, I am very fond of it and I have done nearly 25 to 30 in like since my independent practice. So I am fond of it, and it's not like I'm extending the indication, but I'm doing at proper indications where primary stones are there, which I have some examples in the later slides. So it's a durable one-stage management of difficult and endoscopically challenging CBD stones. This one-stage management is the in thing. This laparoscopic CBD exploration, this open CBD exploration, and bilioenteric bypass. These all three qualify in the single stage management of the CBD stone. So this is a very good thing because their recurrence is only 3% in the long run. Surgical procedure included in the bilioenteric bypass are CBD, this I have bilioenteric bypass are choledocho-duodenostomy, a diamond-shaped side-to-side interrupted or continuous, which depends on the choice, or I do interrupted. Choledocho-jejunostomy, maybe a loop choledocho-jejunostomy if one wants to do a fast surgery. But I'll recommend Roux-en-Y hepatico-jejunostomy or a choledocho-jejunostomy. Sometimes in the text it is mentioned that resection of the CBD, which I have not done ever, but resection of the CBD with end-to side Roux-en-Y reconstruction can be done. Laparoscopic bilioenteric bypass can be done, like laparoscopic CDD. Hands-on only one case I have this bad experience. And in laparoscopic procedure, only difference with the open is that they do posterior continuous and they use TDS, and anterior interrupted or maybe both continuous sutures are placed in HJ, hepatogenostomy. TDD can also be done laparoscopically. Cholecystojejunostomy. In this slide only, I have written that cholecystojejunostomy doesn't qualify for BEA. But I had to change this sentence because cholecystojejunostomy is quoted in textbooks as a bilioenteric bypass. Cholecystoduodenostomy also can be called as a bilioenteric bypass. The drawback of choosing simplest operation like CBD exploration with only T-tube drainage or only where bilioenteric bypass is indicated. The drawbacks are a few because whenever we want to see this T-tube, lower end of the T-tube, like the lower picture where the dye is contrast is going in the duodenum freely. But in the first picture, this contrast is getting stuck with some stone at the lower end. So post cholecystectomy and CBD exploration, lower end sludge or stone or a impacted stone can be a real problem. But and bilioantic bypass can be done only in the really indicated cases where too many primary stones or a dilated duct is there, as we have already mentioned. So, unconfirmed lower end clearance can give you problems in the post-op. And in type 2, as Mirizi syndrome, as I have already discussed. This is an example of, because endoscopic stenting is a temporary procedure sometimes, because to postpone the sepsis or to treat the sepsis, they put the stent and they avoid the clearance of the CBD, and the clearance is left to later on a time. This picture on the first picture shows a large CBD stone in a 65-year-old female patient where it is remaining after a forgotten stent. So sometimes they put the stent and they forget the stent after improvement of the sepsis. No follow up is not there. So this type of stones qualify for bilioantic bypass. In the second picture, as we can see, the mid CBD obstruction type picture is there. There is a CBD stone which is masquerading as cholangiocarcinoma. In this case, we went in the surgery, and after dissection and mobilization of the HDL by both posterior and anterior palpation, it was felt that it was a large 3 centimeter size stone. And in fact, we sent an FNA also fearing that it may be cholangiosphere. Till the surgery, we had no differentiation even with MRI, MRCP, and contrast MR and CT also. So this was a stone which was removed and bilioantic bypass. It was an 75-year-old male. So it was bypass, and later on there was no issues with the patient's biliary system. So intraoperative assessment is important, and CBD clearance and CBD should be done. Forgotten displaced stent. One more picture I am showing. This is a stent which got displaced in the duodenum posteriorly inside the pancreas. We removed the stent, and Choledocho-duodenostomy was done after clearance of the CBD. But the CDD is a very favorable procedure because any lower end stone which is remaining, or a partial clearance is there, or is there any anatomical issues like stuck lower CBD stones, or you're not sure about the clearance, then CDD gives you relief from those issues of post-operative pain and all. This picture is very important. In the right side, the CT picture, which is showing, this is showing a forgotten CBD stent. Again, lots of sludge and stone is forming around the stent, as we are seeing in the CBD. And this picture is of a very an old patient. The patient was not old, actually, the case is old. So, a long time back, this case came to us with the biliary obstruction and query biliary stone. ERCP was not successful, although anatomical alteration we did not know while doing ERCP. And after opening, to our surprise, there was a cholecystogenosmy. A loop was stuck to the gallbladder, as we can see. Cholecystogenosmy was present. We transected this loop jejunum, removed the gallbladder, and we closed both of the ends of the jejunum. And there was a jejunostomy also, as we can see in the picture JJ. And these both ends, one end which was dysfunctional was utilized as a hepatico-jejunostomy loop, like a sort of Roux and Y we created after clearance of the CBD. To our surprise, this cholecystogenosmy was done 15 or 20 years back, and this gallbladder had C1b malignancy. So that is important to know, that unremoved gallbladder, even with bypass, can give pathologies, and it would have gone unnoticed if she did not have any CBD stone. So this case is of a old patient. He was 87-year-old male with a history of cholecystectomy 1 year back, and a residual gallbladder, small residual gallbladder, and CBD stone were there. CBD was 1.5 centimeter with resolving cholangitis. We did a CBD exploration and choledocho. This video is not running here, otherwise it was running in the. It's okay. So this video is not running here. Transduodenal sphincteroplasty. Similarly, transduodenal sphincteroplasty is a very rare procedure. I think most of our time residents and doctors have not seen this procedure or not experienced this. Sorry for that horizontal picture. As we can see, this MRCP, there's a faceted small 0.75 centimeter size stone, which was not being removed with the ERCP procedure. So faceted stone not accessible to ERCP or choledochotomy. MRCP information was very accurate and direct. So we did a direct colidoco, sorry, we did a direct transduodenal sphincteroplasty. So sphincteroplasty, one should know the technique as well as one should notice what ERCP people do, transduodenal sphincterotomy, endoscopic papillotomy they do. So these procedures need to be learned and read about and experienced. This stone was removed with great effort because it was very deep-seated stone, and the fine sutures vital were used to reconstruct the papilla. There was no leak or no pancreatitis in the post-op period. I'll try to run two small videos at the end if the system allows, because not very big videos, but it's okay. This case is portal biliopathy after shunt. PSRS was done, although we get less of them in the private practice, but post PSRS, this patient came back to us for portal biliopathy thing, and we worked it up, and it was not amenable to stenting. Repeated stenting was done, but recurrent jaundice was there. So shunt was functioning, and we did this hepatico-duodenostomy, although there was a grade 1 fibrosis in the liver in the previous biopsy, but this patient went in a liver failure post-op and did not sustain, did not survive. Although HJ happened, some bleed was there, but not major, but these procedures may be needed once in a while. So risks are, as I've told, that biliary enteric bypass can have a bad leak also. CDD can leak and cause sepsis, bleed, and mortality also. But CDD should be done very carefully because at the location where choledocho-duodenostomy is done, there are too many critical structures and the juices are pancreatic fluid rich. So this is very careful surgery, and I think the leak we cannot afford that leak because we cannot offer food to the patient for till the leak heals, and very less procedures are there to tide over the crisis if leak happens. I think we should put some discussion on this leak thing and how to manage that, but I have not included that in my slides. Careful case selection should be there. Hepatico-duodenostomy rule loop HJ leaks can be managed with drainage and antibiotics. Transduodenal sphincterotomy is risky surgery. Leaks can be fatal. Exact direction and depth of the papillotomy and repair is not. Although percutaneous procedures to drain HJ strictures are there, because when HJ gets strictured, hepatico-duodenostomy strictures, they can be operated upon also, but many of the centers, many of the clinicians send them to the interventional radiologist. There they dilate them and they put some stent, temporary or permanent stents. But I have encountered one case where there were mechanical wire breakage. I have given the link of that article in the below black box. So that HJ stricture and the broken stent, removed it and did the redo HJ. So that biliary enteric bypass may be needed sometimes. The roadblock in choosing biliary enteric bypass is, as I've said, that large CBD stones are falling in overlap domain of medical and surgical gastroenterologists. So most of them end up with medical gastroenterologists. If they're expert, they remove them sequentially. But a roadblock for them is that if it's costing them more than 15 to 20 minutes to remove those stones, they need to do in a second procedure, and the patient is in sedation. These patients are sick, septic patients, and they are old patients. So for primary biliary stone, if they're doing endoscopic procedures, they may need a multiple settings. But problem is that patient also wants to avoid surgery at any cost, and they focus on symptom relief. So as soon as stent is put, the patient disappears from the follow-up. So surgical indications or a patient turning up to the surgery or patient being sent to the surgery are less nowadays. So this is a roadblock in choosing BF. Surgical training is deficient in such case. Exposure and hands-on nowadays. Diagnostic challenge is definitely there. These patients are sick, and sometimes the instead of key tube drainage, this biliary enteric bypass patient needs to stay more in the hospital. So 4 5 days of stay and cost concerns may be there. Sometimes the anatomy may be bad. There may be adhesions or a previous history of surgery or pancreatitis may be a problem in choosing or executing this procedure. So in the results thing, the best thing is about the biliary enteric bypasses, they are very durable procedure. If we see the primary CBD stone follow-up with ERCP, there are higher recurrence rate like 46% up to. And in fact, open surgical exploration may have a higher, maybe 29% type of, up to 20, sorry, lithotripsy may have 29% return. But in the surgical bile duct exploration with lithotripsy or with other T-tube drainage or choledocho-duodenostomy, 3% of the recurrence rate of the stones is there, which is a very, it shows that it's a very good procedure. Slight overlap is there in the indications of these procedure, but choose the better procedure whenever indicated. One of the main complication of the later procedure is some syndrome, which develops in 1% of the patient when food and debris gets stagnation in the distal part of the CBD, distal to the anastomosis. The take-home message is that these are large, common, less common operations, but give durable quality of result when performed accurately in right patients. In fact, when indicated, no other modality of treating CBD stone can replace these procedures. Need to increase the training about the bilioenteric bypass procedure in surgical students armamentarium. Thank you all for listening.
Thank you, Dr. Monica. Dr. Ibrarullah, your comments.
Yeah, I think let me just make two quick comments. Like choledocho-duodenostomy, personally, I feel is a very good procedure. Every surgeon who is doing CBD surgery should be familiar with or should, master that technique, because this is very good as a primary procedure for multiple CBD stones as well as a salvage procedures. When you are in difficulty, CBD packed with stones, you are not sure of complete clearance, or you cannot be sure of complete clearance when there are multiple or CBDs packed with stones. This procedure comes as a rescue. And third situation is like recently I faced in my 30 years of career, excuse me. There's only last month that I had a stone which was impacted at the lower end, which the ERCPist tried but failed. And during surgery, I thought I'll go and remove it. Tried my best, just could not remove it through transcholedochal exploration. Then I did a sphincteroplasty. I mean, I went through did a duodenotomy, approached the sphincter, yet I could not deliver the stone. It was so firmly impacted there. Then finally, as a rescue procedure, I left the stone as such, did a choledocho-duodenostomy, and that sort of, the patient improved with that. So at least these situations I would remember that choledocho-duodenostomy per se, personally, I feel is a very good technique, and one should be aware of or be familiar with. And as regards transduodenal sphincteroplasty, I think the indications are very limited, particularly when your ERCP facility is available these days. Endoscopist, for example, I do ERCP myself. I can do a such adequate sphincteroplasty or sphincterotomy that you rarely, need a surgical sphincteroplasty for that purpose. But yes, there are times when there are impacted stones which cannot be delivered by supraduodenal choledochotomy. You may have to approach it transduodenally by, sphincteroplasty. That time, do a sphincterotomy, just convert it to sphincteroplasty, means put a few sutures to secure the thing. So that's all from me.